And let me start by introducing myself. I'm Bhadelia, and I am the director of Boston University Center for Emerging Infectious Diseases Policy and Research. And we are a policy think tank. We are a research multidisciplinary organization. And a big part of what we do is try to build resilience against emerging infectious diseases and address both scientific as well as societal questions about how we build that resilience. I'm so excited that we're getting to host this very important panel with some really incredible speakers to really address our ongoing battle with COVID-19 and how we strike the right balances between ensuring that we appreciate the gains that we made while keeping an eye on the horizon, as well as remaining vigilant against the costs of this ongoing pandemic. So let me start by introducing Dr. Madad, who will speak a little bit more about Belfer Center, as well as the panel, and introduce the panelists. Dr. Madad is an internationally recognized leader and epidemiologist in public health and special pathogens preparedness. She serves as a senior director for systems-wide special pathogens program at New York City Health and Hospitals. She's the co-principal investigator of New York City Health and Hospitals Institute for Infectious Diseases and Disaster Management, and Health and Safety Lead for Enhanced Investigations of NYU's Test and Trace Corps. She's also core faculty at NETEC, the National Emerging Special Pathogens Training and Education Center, and an adjunct senior fellow at Federation of American Scientists, as well as the Bloomberg School of Public Health Center for Health Security. And most importantly, she is also a member at our center, at BU Center for Emerging Infectious Diseases Policy and Research. I'll turn it over to Syra. Thank you.
Thank you so much, Naheed, for that kind introduction. So it's my pleasure to introduce our three amazing panelists today. So I'm going to go ahead and read just a couple of sentences from their bio, but they are extremely accomplished. And so if you'd like to learn more about their backgrounds, feel free to go to the event page and read more on their bio. But our first speaker is Dr. Celine Younder. She's the Senior Fellow and Editor at Large for Public Health, Kaiser Health News. She's an infectious disease specialist and epidemiologist at NYU and Bellevue Hospital, and host of the Epidemic and American Diagnosis podcast. Next, we have Dr. Rodgers Ayebare. He's a sepsis clinician and infection preventionist and infectious disease scientist. He's interested in outbreak surge capacity development and deployment at Ugandan hospitals and primary healthcare facilities. And Dr. Bill Hanage is an associate professor of epidemiology in the Center for Clinical Disease Dynamics at Harvard T.H. Chan School of Public Health. His research and teaching focus is on epidemiology of infectious disease and the evolution of infectious agents. So thank you all three for joining. We're going to have a really robust discussion, and we have a number of different questions that we're going to go through. So I'm just going to dive right into it. So I have questions for each of our panelists. And if you have anything that you would like to add on to another panelist, feel free to go ahead and provide your feedback. So the first question we're going to have for Dr. Hanage, how do we differentiate between epidemic, endemic, and pandemic phases, and why does this matter?
Well, first of all, thanks everybody for hosting this, for having this. It's a really important discussion to be having at this point, and I hope that I'm going to be able to shed a little light on some of these things. So the first thing to understand about this is that the epidemic phase of a disease in a theoretical environment consists of this up and down of infections driven by immunity, which is accumulating and managing to make the infection start to decline at this point. That's a theoretical concept. In reality, things like that very rarely happen because people move around a lot instead, and we sort of have different contact patterns. And that period at the end, when the amount of disease is determined by how many people are becoming susceptible, either because they're new people being born or people have waning immunity, is considered to be the endemic phase to a modeler. So that's what that's what mathematical modelers mean when you say endemic. If you talk to a field epidemiologist, they will say it just means a relatively stable amount of disease transmitting within the community. It doesn't mean that there's not very much disease. You know, it does not mean that the disease is mild, and it doesn't mean that very few people die, because in many parts of the world, tuberculosis is endemic and a lot of people die, which comes back to this kind of folk definition of endemicity, which is, it's the amount of disease that we are willing to ignore or that we're willing to accept as the price of living the lives that we do. And I think that a lot of us who work in infectious disease have been working for a long time to try and get people to do a little bit more to reduce endemic disease over the last few years. And so when we think about that, we have to bear that in mind. And I think my favorite current definition of endemic, or when COVID will be endemic, COVID will be endemic when people stop asking me to go on webinars and explain what endemic means, pretty much. If you also asked me to explain what a pandemic is, then pandemic is when something emerges and is not only causing an epidemic in one particular context, in one continent, but in multiple regions. WHO identifies it on the basis of regions of the World Health Organization, but it means an epidemic which is of global significance. And I think we can all agree that's exactly what we have seen the last couple of years.
Thank you. And I think your points are really well taken. So endemic does not mean that we're not in a dangerous phase. It still could mean that you may
certainly
see,
not.
Yeah, high levels of morbidity and mortality. So thank you so much for that. So this transitioned well into our next question for Dr. Gounder. So you co-authored a really amazing piece in JAMA with a number of different co-authors. And you discuss a national strategy for the new normal of life with COVID, exploring goals and looking at other respiratory illnesses as a guide to assess risk tolerance. And in that particular JAMA piece, you measured, risk thresholds, and you put a worst case scenario and you combined respiratory illnesses like flu and RSV. And in that piece, you had mentioned in terms of, risk tolerance and threshold at 35,000 hospitalizations and 3,000 deaths per week. We'd love to, hear from you. Are there signs we can look for heralding this transition from emergency pandemic state to a phase where we learn to live with this virus? And do the metrics that you shared in that JAMA piece, do they still hold currently?
Yeah, thanks for that. So what I would start by saying is, well, why did we not focus on cases in that JAMA piece as opposed to hospitalizations and deaths? And that's really because even with the excellent, highly effective vaccines that we have, you're not going to be able to prevent all infections. You're not going to be able to prevent all transmission. And there are a number of other factors that make it very difficult to adopt a zero COVID or elimination strategy. Partly because this is such a highly infectious pathogen, partly because your incubation period is so short. With Omicron, could be as short as 2 to 3 days. With even somebody who is vaccinated can still have a breakthrough infection because there is some time that it takes for your memory immune response to kick in and fight off the infection. You also have quite a number of non-human reservoirs for infection, which makes this challenging. And unlike smallpox, which had a very long incubation period, with smallpox at something like 14 days, and is highly visible clinically speaking. You don't have a lot of asymptomatic infection, or didn't have, I should say, a lot of asymptomatic infection with smallpox. You could identify cases readily and do what's called ring vaccination, where you vaccinate everybody around a case. That those kinds of strategies that have been used with other infectious diseases really are not practical with COVID. And so our best hope is to control it. But then the question is, do you control it at a high level or at a low level? And to Bill's point, endemicity, essentially a state of control, can still lead to a lot of disease and death. So then we looked at, okay, so if we're going to focus on hospitalizations and deaths, what is a meaningful level, or what is a level that society has shown it is willing to tolerate? And so we looked at a composite of influenza and RSV, and now that would also include COVID, but influenza and RSV pre-COVID were the two big viral respiratory illnesses that would land people in the hospital and that would kill people. And so if you look at the highest severity years in the pre-COVID era, that translates from flu and RSV to about 3,000 deaths per week. Currently, just to put this in context, we have about 9,000 deaths from COVID per week. So we're just from COVID alone at 3 times the prior historic threshold for numbers of deaths. And also in terms of hospitalizations, we're currently at about 30,000 new hospitalizations from COVID per week, which is actually about the level of viral respiratory illness hospitalizations in high severity years in the past. But if you're trying to reach a composite from all three in terms of including COVID, flu, and RSV, if you're trying to reach a composite that is comparable to severe years pre-COVID, we still have a lot of work to do. We proposed using these kinds of thresholds to help signal when public health mitigation measures might be reinstituted. So that might include recommendations about masking, gathering in certain public spaces, say indoor dining, and then also as a way for healthcare systems to assess when they might be heading into a danger zone, when they might get overwhelmed with cases. I think one use of this kind of threshold hospitalizations, deaths that we're now seeing is with respect to the new CDC mask guidance, which is really about and framed in terms of how do you protect the healthcare system. And I don't think that's really been well understood. If you look at what feeds into that map of green, yellow, red, in terms of where it's advised you wear a mask, they're taking into account not just cases, but hospitalizations and hospital capacity. And so that's really about saying, if you don't wear a mask and you get sick, are the hospitals in your area able to cope with that burden and provide you with normal standards of care? That's very different from saying your risk of getting COVID in the community is low. And so I think that's an important distinction to be making here. And then finally, that CDC guidance, if you back calculate what level of death that translates to, that is essentially about 1,000 deaths a day or 7,000 deaths per week. And that's significantly higher than what we have tolerated from the combined total from influenza and RSV in the past. So I think, there's a combination of what metrics you use, but then at what level you draw the line. And I'll just conclude by saying here, Ed Yong had a great piece in The Atlantic this week where he talks a bit about this and how it is that we've tolerated 1 million deaths in this country, and makes the point that it's not clear that people really do understand the death toll, even from influenza and RSV in the past, and using that as sort of what is society and the economy willing to bear may in fact not be the right place to start the conversation. And so I thought that was really thoughtful observation on Ed's part.
Yeah, I'm so glad that you brought up that piece from Ed. I was just going to mention, I think these are all man-made frameworks, that we are putting together, and we're saying that we can tolerate it. So I think those were some really, really excellent points. Thank you so much. So my next question is for Dr. Ayebare. The end of the surge here in the US doesn't mean the end of the pandemic. I think that's, unfortunately, that's getting muddied in the media, where I think a lot of folks here in the US, they've put the pandemic behind us, kind of going back to our pre-pandemic life, but we know the virus obviously is still circulating in the community. We're still seeing high levels of cases in many other countries. So there's still rising cases, number of COVID, cases around the world, for example, obviously in Hong Kong. What does endemicity look like in the global context?
No, thank you so much for that great question. And I'd like to thank the previous panelists for setting the stage. So looking at endemicity globally, or how we get there, even looking at the numbers that we are having currently, you see that the cases are going down. However, if you compare with the previous peaks we've had over the last 2 years, even at our current low from this Omicron variant, we are still over all the previous peaks by tens of thousands of cases, meaning we still have quite a long way to go. But also looking at endemicity globally would not paint a clear picture, meaning we'd have to unpack the numbers we are seeing to appreciate context-specific factors, which are accounting for the trends we are seeing, or even how we get to endemicity. So, for example, most high income countries, have older populations, and they have also equally had early access to vaccines. So, if you're to consider the stability that Bill talked about, if you have a tab, with water coming in, meaning the new cases, and water going out, or the amount of immunity being generated, then in such a case, you would expect maybe waning of immunity would be a key factor to consider. But in most low-income settings, they have quite a young population, and also plus the other artificial factor that we've created of, inequality in vaccine access. Then it means in the long run, or for every year, where you have a small population, you will have population explosions. By this time next year, we shall have about 3 to 5% of new school children, of new school going children, in Africa, all those who have been born over these years of the pandemic. And, you have this susceptible population growing. So, unfortunately, of course, endemicity in itself does not give us actionable information on how we decide how to live with the virus. And we might also have the myth that endemicity means the future with the virus will be better than we've had so far. And, it means we are more or less tempted to bet on the fact that the virus might play nice in the coming years. But we know that might not be the case. So globally, as we, cases go towards endemicity, or even once we get there, globally we stand a risk, or there's a potential of seeing widening disparities in the global fight against COVID, with at least those who have access to tools like vaccines, moving on and participating in the global economy quickly, and those without, having to endure longer nights through the thick of the pandemic. Or, once we say, oh, endemicity is here, and we use as an excuse not to care, then we risk being caught flat-footed, when we have resurgences, or if the disease indeed stabilizes at higher threshold that will strain the health system, and also lead to resurgence of other previously controlled infectious diseases. But then also, perhaps our gamble might be on the money, and indeed the virus becomes weaker, and the virus gets to play nice. But for now, who knows? So I think it's better to err on the side of caution than letting everything to the determination of how the virus mutates. Thanks.
Yeah, we're certainly dealing with a shape-shifting virus. It's really hard to predict next steps. So next question is for both Dr. Gounder and Dr. Hanage. So the wild card of the pandemic is variants. And, as we look at obviously the history of variants, we typically see a new variant of concern almost every 6 months or so. So we don't know if the next variant will actually be a variant of concern, or how it'll emerge. Could it be a spillover from an animal reservoir, or from a person with chronic illness? If it'll cause severe disease, and if our vaccines will protect against this new variant. There's also uncertainty on the longevity of our immunity. Can you share what factors contribute or detract from COVID-19 becoming endemic? And maybe we'll start with Bill first.
Wow, variants. You call them a wild card, they certainly are. So the first thing to note is that the situation is not only always changing for us in terms of the virus, it's also changing for the virus, because the proportion of the human population that is immune is changing. Also, the types of behavior humans are engaging in, the opportunities for transmission, they're also changing. Predicting exactly what a variant is going to do and how it's going to behave is very difficult, and I don't even want to get engaged in it, other than to point out, as what has become something of a catchphrase for me, I never bet against natural selection. So we can certainly expect that if a variant arises which is better able to transmit into the current context than those that we currently have, it will take over. Now, one thing I can tell you is that by taking our eye off the ball, we are losing the ability to respond appropriately to it. We are effectively gambling that the properties of that variant are going to be relatively benign. And in the case of Omicron, they certainly do seem to have been. There are two parts to Omicron's relative benign nature. One of them is the fact that lots of people are immune. And the other is the fact that Omicron does appear to be intrinsically less nasty than the preceding Delta variant. But don't get your hopes up, because of the preceding variants, Alpha was more dangerous than the preceding virus, the original strain. Delta was yet more dangerous than Alpha. And so with Omicron, we're in a better state than we would have been, but we have no guarantee that's going to continue. And evolution really, when people who tell you the virus has evolved to become more benign, usually have not made much study of evolution. What we do have instead is accumulating immunity in the population. And what that means is that the type of disease that future variants cause is less likely to be severe. And one of the things which is very encouraging is we have seen quite broad protection from the vaccines that we have against quite a wide range of variants when it comes to severe disease. Not, it's not perfect, but it's a heck of a lot better than it might have been. And before I hand over to Dr. Gounder, I want to point out something in our discussions of this that I really think that I want to just bring up here. Because of the fact that we're always talking about how much risk there still is, and I'm not going to lie, there is still risk. And because we're always talking about how many people have lost their lives, and it's a truly extraordinary number, I just want to put in front of all our minds the fact that we have actually saved a lot of lives as well. And the sacrifices people have made, the people who have managed to be able to get vaccinated, the people who had the chance to be vaccinated before they were infected, and so their lives were preserved. It's going to be very difficult to count them, but I do want to remember them as well.
I would concur with everything that Bill has said. I might just include a couple other comments, really just reframing some of the same things. I think about this in terms of sort of along three different axes. You have the axis of the virus, the axis of our immune systems, and then the axis of human adaptation and behavior. So sort of three dimensions, which defines the space of what COVID will do. And so for the virus, you have the rate of mutation. So is it going to mutate more gradually or in leaps and bounds? If you have a virus that's mutating more gradually, it's likely that you're going to see more of a seasonal pattern at times when people are gathered more indoors. So usually in the winter months, you're likely to see more transmission. Whereas if you have a virus that is mutating in leaps and bounds, you're more likely to see transmission outside of that cold winter season at other times of year. And I think another key factor here is when you have a new variant emerge, some of the most important determinants of whether this is going to lead to another epidemic surge would be, is it highly transmissible, more transmissible than prior variants? And also very importantly, is it immune evading? And in the case of Omicron, it was both. Also with Delta, it had properties of both. And that's partly why you saw both of those variants contributing to surges. Some have argued, and this was even before the emergence of Omicron, that the virus had reached peak fitness. And then you have Omicron that emerged with an additional 50 mutations, and as Bill said, I would not bet against natural selection. I think it is highly unlikely that the virus has achieved peak fitness. We likely will see further mutation of the virus. And the key areas of vulnerability are people who are not vaccinated, who have no immunity, because you're going to see much more transmission, spread, replication of the virus in those populations. And so higher risk of emergence of variants. Secondly, the immunocompromised, and there are a wide range of reasons somebody might be immunocompromised, ranging from HIV/AIDS to therapeutics for cancer. And we've seen highly immunocompromised persons develop chronic infections where there's risk of mutation over time and emergence of an immune evading variant in that way. And then finally, zoonotic transmission is another possible source of variants, and we are seeing now transmission of SARS-CoV-2 among a number of different animal hosts. We have seen some spillback transmission back into humans from animal hosts, but it's unclear that we, so far as yet, we have not seen any variant that seems to be the result of zoonotic transmission and then spilled back over. With respect to immunity, this is really a function of the duration of immunity, the quality of immunity, and there are certainly some things we can do to enhance that. That might mean new vaccine technologies in addition to the injectable vaccines, perhaps using mucosal vaccines to improve immunity on mucosal surfaces, so in the upper airway. I would envision that being in addition to, not instead of, injectable vaccines, perhaps using different adjuvants, which are used to enhance the immunogenicity, the immune reaction to vaccination. Skin microarray patches also seem to be an interesting technology. They're in some cases more acceptable to people because they don't involve the needles. They're more of like almost like a Velcro patch that you apply. And it also allows, excuse me, for metered out dosing over time of a vaccination as opposed to a one-time bolus. And there do seem to be immune benefits to doing that as well. I think we also need to be thinking about our vaccination programs and ongoing efforts to how we vaccinate people. In the US, in any case, we've reached about 2/3 of the population that's fully vaccinated now, but there's still a significant proportion of the population that is not vaccinated, and they do tend to cluster more so together. And then finally, this question of human adaptation and behavior. And do we approach this with the idea that, well, we're moving on, we're not going to worry about this anymore, which frankly is how we've approached just about every other infectious disease in the past. When there was a fourth wave of influenza back during the 1918 flu, people didn't really respond to that. If you look at what's happened over time with Ebola, Zika, HIV, and so on, there tends to be these waxing and waning of attention, of funding. So we can approach this from a just in case, or we can approach this when the next crisis hits and institute mitigation measures at that point in time. I also think, in terms of human adaptation, you have sort of the individual clinical approach with things like masking or testing. Do you isolate if you're infectious, or do you quarantine yourself if you think you might be have been infected? Do you seek treatment promptly, or are you facing barriers to treatment? And then from a collective or public health perspective, do we finally start to make improvements in things like indoor air quality through upgrading ventilation and air filtration? Do we institute safety nets like paid sick and family medical leave that allows people to stay home and reduce the risk of transmission at work or at school? And do we offer safety nets like disability programs for people who have developed COVID and maybe have long-term consequences, sequelae in the form of long COVID? So, I think these are the different ways I think about how do we make this transition, what predicts that transition, and what that will look like.
Excellent points. Thank you so much for hitting up on all of those really key topics. Dr. Hanage, in President Biden's State of the Union, he stated, we, and to be clear, just means the United States, have reached a new moment in the fight against COVID-19. And that's because of the progress we've made this past year. COVID-19 need no longer control our lives, as he's mentioned. We now also have updated CDC guidance, and then the White House recently, just shared their new national strategy for COVID-19. Do these new guidances and policies reflect where we truly are in this pandemic? Do they help us in achieving the transition to an endemic state? And what would a world with endemic COVID-19 actually look like?
Well, what kind of world do you want? What are you trying to achieve? What is your goal? What level of endemicity is considered to be tolerable? Exactly what we heard right at the start. Dr. Gounder pointed out that the hospitalizations right now are, around those that they would be considered to be in a pretty rough winter, nationally speaking. Well, you'll also hear other people say, oh, the hospitalizations right now are as low as they have been since July last year. That should give you pause and just think exactly how long we've been struggling with such a large amount of hospitalizations and such a large amount of illness and death. And to be fair, even though I think that it's true that we are at a very different stage in the pandemic, that's partially due to the stuff that we've done as humans. It's also due to Omicron having infected very large numbers of people and left them with some immunity. And so I don't think we can forget that. Now, moving forward to ask what is, what's appropriate in different parts of the country, you said that this is applying to the United States rather than the world. But the United States is a pretty variable place. It's not so much e pluribus unum, it's e pluribus pluribus. I'm probably getting the Latin wrong there, but there's a lot of very different places, and the consequences of the withdrawal of mandates will be variable. We've already seen very stark disparities and inequities in the toll of the pandemic on different communities over the last 2 years. That is likely to be maintained in the coming months. And it is likely to be, it is likely to continue as we start putting more responsibility on individuals and their ability to protect themselves. I want to underline everything that was just said about things like testing, about things like the ability to avoid presenteeism, sick leave. For goodness sakes, why have we talked so little about sick leave? Something which would not only avoid worse COVID surges in future, but would avoid worse flu seasons, but which would help avoid worse outbreaks of all sorts of infectious agents. So we really should be talking about all those things. But in terms of what it's going to look like, I strongly suspect that the endemic world that we are heading towards, one thing I wanted to point out. You remember the State of the Union? You saw everybody not wearing their masks. What you didn't see was that they did rapid tests beforehand. So that's an example of how moving forward, people can manage to calibrate the risk that they're under by taking various different steps and perhaps removing masks, but having done a test beforehand. So if only they had done that, there would have been an opportunity for really good messaging about how individuals can handle the pandemic going forward. But I wanted to talk about what I think we can anticipate the next stages of this transition to endemicity to look like. And this is assuming no new variants. If we get new variants, I'm going to come back on and talk to you about it. But until then, let's assume no new variants. The relaxations, which we are seeing, are going to lead to more infections. Now, the question we now need to ask is, how consequential are those infections going to be? Are they going to be leading to a level of hospitalization and serious illness, which is going to mean that people cannot receive the care which they deserve? And if it is done, that's quite possibly going to be managed relatively effectively if we see sufficient contribution from seasonality, because people have made very different contact patterns over the last couple of summers. We don't know that that's going to be the case with lots of restrictions being removed. People may crowd indoors. If you want to see what the winter is going to look like, once again, go and look at Florida in the summer. And then at some point, seasonality will turn against us once more. We will have people making more contacts, and we'll be seeing a large number of infections in the fall and winter. I'm not going to say exactly how many, but just to point out that they won't be trivial. They will peak probably as the last 2 years have. And in fact, as the other human coronaviruses do, around the second week of January, reflecting transmission happening over the holidays. And a certain number of people, most of them vulnerable, but not all of them for other reasons, will be hospitalized, and some of them will sadly die. Now, whether that happens in numbers which are considered unacceptable is not a scientific question, it's a question of values. And unfortunately, I can share with you my values, but and if you tell me what you would like to achieve, I can help you achieve it. But I think we need to be straight with people and ask them, what do they want to achieve? Sadly, there's a very large constituency in this country that is entirely fine with 1 million people dying here. And I think that we have to go and make the case for public health with greater force and greater vigor.
Yeah, excellent points. And I think the one thing that I'll just quickly point out, I'd love to hear what all three of you have in terms of feedback is, more and more new data is coming out on the impact of infection, whether it's asymptomatic, mild, moderate, severe, and the impact that it has on the brain, on the heart. More and more data is coming out. And so as we look at the stage that we're in, so much focus is on preventing hospitalization, but should we go back to looking at really making sure that we are preventing infection? What are your thoughts? Anybody have anything that they'd like to share?
I would just say, I think it's going to be exceedingly difficult for the reasons I outlined earlier to prevent all infection. There are some measures that we still haven't taken to scale to reduce infection though. So that includes improving indoor air quality through enhanced ventilation and air filtration. That could really make a difference. And that's one that does not require individual action or compliance. Another is, as Bill has also talked about, is providing people with paid sick and family medical leave so that they don't have to go to work or school when they're sick and contagious to others. So those two interventions alone could make a huge difference here. We are also seeing with respect to long COVID, and I think this is why so many people have been so afraid of getting even a breakthrough infection, a mild infection, is they're afraid of getting long COVID. And I think that fear needs to be acknowledged. We are seeing, though, in people who have gotten vaccinated, the risk of developing long COVID, if you then have a breakthrough infection, is reduced. It is not zero, but it is much lower. And I think one of the studies I would really like to see conducted now that we have antivirals is if you diagnose and treat someone promptly with antivirals, medications like Paxlovid, do you further reduce the risk of progression to long COVID?
Yeah.
That's a superb. That's a really good study idea. I would echo the point that over the later 19th and 20th century, we saw a great deal of benefit to public health from improved sanitation, which reduced, which sadly is still ongoing in parts of the world, but it has largely reduced the incidence of morbidity and mortality from various diarrheal diseases. Now, some people could argue that this pandemic has shown that we should do the same kind of things for our air, the air we breathe, and that would have benefits way and beyond the present pandemic.
Yeah, excellent points. Excellent points. Dr. Ayebare, I have a question for you as an infection professionist. Do you have any significant lessons learned from your experience with COVID-19, as well as collective experience that we can apply to future infectious disease threats, as well as current respiratory illnesses that we continue to deal with?
No, thank you so much for that question. And I think it really feeds directly into the work that I've been doing over the last couple of years. And well, of course, there are a couple of lessons, but three lessons stand out for me. And I think the debate around COVID-19 transmission and selection of PPE has been the most significant learning moment because indeed from a lay person's perspective, we've seen the recommendation of face coverings, all the way from respirators at the start of the pandemic down to surgical masks, then cloth masks, then double masking, and back to respirators. And although for a lay person, this is a bit of shifting goalposts to end up at the one inevitable outcome. At least demonstrates the robustness of the scientific process and adapting to new information. But for as a practitioner in a low resource setting, it poses a challenge on how we engage healthcare workers, especially in an ecosystem where we still utilize paper-based documents to disseminate guidelines. So meaning before you actually finish sensitizing people on one thing, then new evidence has come out and you have to reinvent that wheel again. So leveraging platforms like communities of practice where you talk to people in real time can help overcome that challenge. Also, the sheer cost of PPE is, to put it politely, insane. I do work with a colleague who works at the Wirral Hospital in Liverpool, and we're able to compare their PPE use per month compared to what we had projected for use countrywide. And it emerged that Wirral Hospital, which is an 855-bed referral hospital, utilized more PPE than 3 regional referral hospitals, plus all their other satellite facilities that refer to it combined. And, because the national or, hospital or regional budgets allocated for PPE purchase are so minimal, then even when you look at it in context or, compliance-wise, we are just putting a drop in the ocean, and resources to make PPE available still remains top of the agenda. And I think also the other point that feeds into that is that we are realizing that primary healthcare facilities are the most vulnerable point in the entire health system regarding health security, because although we've normally picked up disease outbreaks at the most resourced hospitals or laboratories, we cannot deny the fact that by the time these patients present at where we have the capacity, they have left a trail of exposures to unsuspecting healthcare workers, to patients, and other members of the community. Therefore, even as we plan for future pandemics and we are planning to deploy countermeasures, it's important that we make safety a universal capability regardless of the level of healthcare, because at least if I'm able to identify you and approach you safely, then the other elements like diagnostics and therapeutics can come. But at least I, as a healthcare worker, should be kept safe to serve the other members of the community to reduce on the domino effect of these infectious disease outbreaks. And also the other one take-home lesson that I've taken with me from this pandemic is that there is no shame in erring on the side of caution. And I think where evidence is not solid or resources may not permit the pragmatic approach of taking the highest level of protection for an unknown threat is, I would recommend that. And then we can always scale downwards once new information regarding transmission dynamics or PPE recommendations becomes available. And also, although cost is an important factor to consider as we make safety recommendations, it should never be the primary metric we should consider to give guidance on healthcare worker safety or community safety regarding such outbreaks. Thanks.
No, that's great. Healthcare worker safety is so important. In fact, I think one of the lessons learned that we're looking at for our own healthcare worker kind of policies and guidances is that we're looking at during heights of other respiratory illnesses, so seasonal flu that we see every year, we have a we have a vax or mask mandate. So if you don't get vaccinated, you have to wear a mask during seasonal flu when it's prevalent. And so now we're shifting towards potentially looking at maybe we ask all healthcare workers to continue masking during the height of seasonal flu, as well as obviously encouraging them to get vaccinated without having a flu vaccine mandate. And so those are some of the discussions that we're having. So how can we protect a healthcare worker, during these ongoing, seasonal flu surges that we often see, and bringing PPE into that conversation. So those are some active conversations. So I'm really glad that you brought that up. I'm going to go back to, our conversation, obviously, of COVID-19 and the transition to it being endemic. Dr. Gounder, you shared communities of color, immunocompromised, and others with underlying health risk medical conditions are getting left behind with the CDC's new mask guidelines. Can you share how we can make sure endemicity reflects better health equity? And I also want to let those that have joined today, if you have questions, please feel free to put it into the chat box as we'll transition into the live Q&A in a moment.
I would say efforts to ensure health equity have to start with data. So if you don't have good data, you can't even see those health inequities. It's very difficult to assess the why, the what to do about it without good data. And I think one of the challenges we have is right now, data that we have on race and ethnicity in particular is really incomplete. It depends on who is collecting that data on the ground and feeding that up through the system that eventually gets reported to places like the CDC. But, you know, we often say in epidemiology and other statistics, garbage in is garbage out. And so if you're not really getting complete data and accurate data, you're not going to be able to assess what those inequities are. And, you know, it's not just completeness. As I said, it has to be accurate. One population that is very often misclassified in terms of race and ethnicity are indigenous peoples in this country, very often misclassified as Latinx or white. And so again, that makes it very difficult to tease out what some of the inequities are. And then secondly, I think this goes back to what are individual approaches versus collective approaches. And collective approaches are really about protecting the population and the most vulnerable in a population. And so I go back to, we really need to maximize use of interventions that don't put burden on the individual, but that do protect the collective and the most vulnerable. And so again, that includes indoor air quality, paid sick and family medical leave. And then in terms of the individual approaches, making sure that the most vulnerable have access, whether that's to testing or to treatment, any of those clinical types of interventions. And what we've seen more recently with efforts to provide free tests to people mailed to the home or through community health centers and food banks, that's really trying to make sure that the most vulnerable are not facing those barriers to testing. Many departments of health have been offering free testing with PCR throughout the pandemic, but not everyone's always necessarily able to get to a public health department clinic in time, and that there are barriers in terms of transportation and time off potentially. And we're also seeing interventions now, like the new Test to Treat program, where you can walk into a pharmacy and some other specific locations, get a test, and if you test positive, walk away with Paxlovid, the antiviral for COVID, and do so without, even if you have no insurance, without a copay, without out-of-pocket costs. And so those kinds of interventions are really important to ensuring health equity. They're really interventions outside of the healthcare system, because the fact is our healthcare system is designed, is structured to create health inequities. And so if we try to route all of our interventions through the healthcare system, we will reproduce those health inequities.
Excellent points. And a reminder to the audience, if you have any questions, feel free to put it into the chat box. So I'm just going to ask, I think a particular question, as you mentioned, the test to treat. So this actually was brought up by Dr. David Ho, and he mentioned that with Paxlovid, in the testing in their lab, they mentioned that the virus has many solutions to evade the drug. And the issue that he raised was sooner or later resistance may develop. And as we look at this test to treat program, which is really great, but it would indiscriminately use Paxlovid, and we may have resistance occurring quite quickly. Do you have any thoughts or any feedback, to this? And as we look at obviously, future generations of antivirals and more innovation, just on this particular drug, do you have any concerns with this, test to treat?
Is that for me, Syra? I think you have that risk with any antimicrobial, that you're going to have resistance. I think it speaks to the need to be continuing to work on developing next generation antivirals. Some of that might also be the antivirals that have fewer side effects. Molnupiravir, the Merck drug, which is also less effective, is concerning with respect to women of reproductive age and the risk of congenital birth defects. Paxlovid has a lot of drug-drug interactions. And and so that, that could also limit its use. And so we need to be developing additional antivirals for a whole host of reasons. With HIV, for example, we didn't stop with the development of the first protease inhibitor. We kept on going, developing more effective, more tolerated, less, or rather more robust to resisting or in the face of the virus mutating and developing resistance. So we do need to continue on that front. And I think the other question is, how can we use these antivirals possibly in combination, just as we do for other infections like HIV or TB, to reduce that likelihood of resistance developing. But I don't think that risk of resistance is an argument against making use of these medications that we have available to us right now. I think it's really a question of how can you keep the development and innovation and other alternatives available to us in the long run.
Yeah, great point. And I think for all of our panelists, love to get your comments on, as we, have these discussions on COVID-19 becoming endemic, really wanting to highlight that that doesn't mean that we should stop in innovation and research. Doesn't mean that we throw our hands up in the air and say, okay, now it's a manageable virus and we don't really have to do much about it. It's actually quite the contrary. Any thoughts, on that for, with all three of the panelists?
I'm really glad you just said exactly what I had in my mind, which was that who told us that endemic means you don't do anything? That's not what endemic means. Yeah. I can guarantee you that. And we should continue to be thinking about what we can do. There are lots of things we can do. You've just heard about a few of them. I would add, actually, if you're wanting to think about potential future mask mandates, if you want to put mask mandates which are most equitable, I would recommend putting them in the places which people cannot avoid using, even if they are if they consider themselves, or if they are in a more vulnerable category, if they're immunosuppressed. Lots of people have to use public transport. Lots of people have to go to grocery stores. Lots of people can't afford to get delivery. So doing things like that is a smart way of doing these things. But also being prepared to roll with the punches, do pandemic management. Remember that you can always get better at it. And we should hopefully get better by thinking about it all the time and by working to be better at it. And I would just add something, I'd reiterate something I said before. We have correctly talked a lot about how many people have lost their lives and how many people have their future lives blighted by long COVID. However, we have also saved many. We may well never know exactly how many, but all of the sacrifices people have endured for the last 2 years should not be considered to be in vain. They have taken a bad situation and stopped it being even worse. And so I think that the point that as we move into a stage where we are treating the virus as endemic, we should recognize that there are things we can continue to do in order to help. And, if people want to help, they can.
Absolutely. And I think that's a really great segue into our last question for all three of you is what can we do to address societal hope for this new normal, but still being cautious amidst a great deal of pandemic fatigue that currently exists? And are there active roles that each of us as average citizens can play in moving collectively towards this transition, of COVID-19 becoming endemic? And maybe we'll first go to Roger to get his thoughts.
Thank you so much. And I really have enjoyed following this discussion, but the disparity in resources means the challenges have to be context specific. So, you might think of the risk of resistance to antivirals, but I'm thinking, antivirals are quite expensive for the setting where I practice. But I think for a real resource setting approach, it's regrettable, the amount of lives that have been lost to COVID, but I believe the impact on livelihoods is what is likely to have a more significant impact, even way after the pandemic has either abated or become endemic. So because we have to live, I think it's important that people should be encouraged to participate in the economy or try to get back to their lives. However, with risk reduction measures built into how either schools or grocery stores or public transport reopens. Therefore, we have to think local, we have to think low cost, and also encourage citizens to use the motivation to save their livelihoods as a motivation for them to, maintain some of these low-cost interventions to at least enable society to continue to function. And also, people should be prepared. We don't know what COVID is going to throw at us in the next few weeks or months. Thanks.
Absolutely. Celine, we'll go to you next.
Oh, sure. So first, sort of also reflecting back on what Bill was saying earlier, if I were to say to you, breast cancer is endemic, if I were to say to you, colon cancer is endemic, would that mean that we would just throw up our hands? We would stop trying to diagnose, we would stop mammograms and colonoscopies, that we would stop doing everything we could to improve treatment outcomes? No, of course not. And I think we have to think about COVID in that same way. Just because it's endemic doesn't mean you give up on actually mitigating the impact and reducing disease and death. In terms of what individuals can do, a couple months ago, I wrote an op-ed with Robert Putnam, who has studied civil society for much of his career. And I think of COVID as really a collective action problem. What are we willing to do on behalf of our community? And some of the solutions that he found after the last period where we had the lowest levels in trust, the lowest sort of societal sense of community in the US anyway, was in that period after the Gilded Age into the progressive era in the early 1900s. And so what are the things that worked historically then? Maybe they'll work now, maybe they won't, but I'll just outline some of those. One was the power of really strong moral voices and people pointing out inequities. At that time, it might have been around child labor or tenement housing. Today, it's about the health inequities of COVID. And that's not just about religious voices. I think some of the most important voices during the pandemic have been some of our friends, people like Tyson Bell or Stella Sappho or Mati Davis, Peter Hotez. I mean, the list goes on and on, Rhea Boyd. There's so many people who have spoken up about health inequities. And I think that's really important to be that moral voice, moral compass in this moment, to have people thinking about why does it matter to be thinking about not just what is good for you, but good for your community and what that balance should be. I think secondly, what worked at that time included really intentional relationship building. And we really need that right now at a moment where we are as polarized as we've ever been, politically, as well as that polarization going right down to the neighborhood level, where your neighbors are very likely to have very similar partisan views as you. And we need to be breaking some of that down to have people thinking about the collective and caring about their neighbors in a way that might have been more the case, say, in the immediate post-World War II era. There are some programs that are intentionally kind of trying to do this. Back in the early 1900s, you had the Rotary Club, which was, its motto said something about service above self. And you have intentional programs now, for example, the Listen First Project, the Living Room Conversations, and others that are really trying to bridge some of those partisan divides. And then I think finally, the power of solving at the local level. A lot of what happens at the local level is the trash getting picked up on time, really solvable things that communities can work on together to rebuild trust. A great example of this, also going back in time, was Lillian Wald and community nursing. Today, we're seeing community health programs, health worker programs across the country, many funded by CDC over the course of the pandemic. Some of the model programs I've seen already are in New York City and in Baltimore, in Chicago. Many of these are trying to identify people from highly affected communities people living there who are trusted by folks there, providing with those workers with tools to be successful, to serve their communities. And I think that's really important because it's highly visible. It's really an extension of public health and government into the community where people see it, they see the results tangibly, and there are people from the community, so they trust them already have some level of trust. And I think that kind of program is going to be really important also to re-energizing a sense of collective and doing things on behalf of one another.
Yeah, excellent points. Really a time to make sure we're building that trust in our community. So thank you so much for pointing that out. Bill, anything that you'd like to add?
Other than echoing absolutely everything I just heard. I mean, yeah, we're going into this, my expertise was in epidemiology and evolutionary biology, but over the last few years, I've been given a crash course in, well, talking to the media and trying to communicate to policymakers and individual human beings the importance of their actions. Because one of the things that is really revealed by infectious disease is that we are not islands. We live embedded in communities, and the risks to ourselves reflect the communities in which we live and the extent to which we contribute to those risks ourselves. So there are lots of things you can do as individuals. As individuals, the most important thing to do is be vaccinated. It's important to be boosted if you're over 65. To be up to date with vaccination might be a better way of putting it, because as time comes forward, other boosters may become necessary. It's important when thinking of resource poor settings to also advocate for vaccines to be equitably available in parts of the world that are not the United States. And it's important to keep your eyes on these things and be working to try and change things. Because as I've said many times, what endemic looks like depends to an extent on what we do. And a better world is possible if only we work to make it so.
Absolutely. The front line starts with you. Thank you to all three of our panelists for an amazing discussion. Really great points that each of you individually and collectively have highlighted. So with that, we're going to end today's seminar. Thank you for all those who have joined and for those that have helped coordinate today's event. So take care, everybody. Thank you.